Welcome to this webinar this morning on a nice chilly morning in Joburg. Hope everybody's doing well. This webinar session is sponsored by SafMed, your solutions partner for the last 30 years. This is the fourth webinar of our Insight series, and this Insight series will continue again later on this year. The Insight series is really based on published papers, latest webinars, latest things that we've learned in the last year or so. So we will continue to keep everybody updated with this regard. Our next webinar series will be focused on sterility assurance. What is the concept of sterility assurance? Why do we need sterility assurance? How do we go about ensuring sterility assurance? But we'll keep you updated with that. What will we cover in today's session? We're going to talk about contamination of sterile solutions in the sterile field. We'll look at the latest AORN updates. We'll have a look at the AORN existing guidelines, but in the context of COVID-19 and how do you apply them. Then we're going to go through some latest published papers from the Australian Association College of Perioperative Nurses, difficult name to say. And lastly, we'll focus on waste management in the operating room, quite an important topic and a difficult one to look at. As I've mentioned before, in the AORN journals, every month there is a section called Clinical Issues. And in Clinical Issues, there is question and answer section. So we're going to go through 3 of these questions that were posted in January 2021. Quite interesting, and looking in depth at all of the answers that were provided. The first question that was posed was, for almost all procedures, the case card contains extra supplies for use later in the procedure or as needed. How should extra unopened sterile items and supplies be stored in the OR when a procedure is in progress? Very good question and a very relevant point to all of us. They begin by acknowledging in the paper that, quite obviously, covering or containing items decreases the risk of splash of airborne particles or and those kind of things contaminating anything and all of our sterile items in the operating room. They then say there are numerous options for covering or containing our sterile items, and they include case carts, plastic bags, a trolley system, or some form of enclosed shelving. In the article, they then also go on to talk about the fact that when you're opening the packs, the operating room staff obviously need to reduce the risk of transferring potential contaminants onto the sterile field, and it makes logical sense, as we all know, to perform hand hygiene before opening our packs, to inspect the items before opening them, and using aseptic techniques when opening our packs. Logical, we do know this already. Of course, they acknowledge that there is evidence that there can be aerolization of bloodborne pathogens and others, from what we understand, when using lasers, diathermy, or some high-speed power tools like bone saws and drills. And that, of course, will and can contaminate your sterile packaging. And that was really it in terms of that question. So we know that things can get spread. We know that we should be containing our items. We know that we should be protecting our sterile supplies. In my experience, we often put lots and lots of extra sterile supplies on standby in the operating room. So let's make sure that we are protecting them and containing them in some way, manner, or form. Then the questions posed were around the solutions in sterile basins, and this was quite an interesting topic for me, one that I'd never really delved into before. This was the question that was posed. An orthopedic surgeon who's new to our facility recommended that we limit the use of solutions placed in sterile basins because of the potential for contamination. The question was, is there evidence of contamination of solutions in basins in the literature? And the very first answer is, indeed, there is. There is evidence of contamination of solutions in sterile basins on surgical instrument tables. And in fact, the contamination rates, as you can see here, range between 2 to 74%. That's quite scary. The bacteria found in the contaminated solutions include Staph aureus, Klebsiella, Pseudomonas. There was quite a long list. I picked 3 of the names that we would be the most familiar with. However, in the research that was reviewed, they didn't always specify what type of solution was in the basin. Was it sterile water? Was it normal saline? What was in the basins? Another point they raised was they didn't specify what the solutions were being used for in this particular research. And what they did note that is that the longer the duration of the procedure, the greater the risk of solution contamination. And in one of the studies, the solution was contaminated 35% of the time when the procedure was longer than 130 minutes. Interesting statistics. Having said that, though, none of the studies actually found a correlation between contamination of solutions and the development of surgical site infections. And therefore, it's really unknown whether contaminated solutions in basins, on the instrument tables, on the sterile field will affect surgical site development. Again, having said that, the next question was posed, how do the solutions used in the sterile basin on the instrument table become contaminated? And can we eliminate or reduce that risk? How do we go about it? And what is the potential for risk for infection? The hypothesis is that the contamination can occur from exposure to airborne particles in the operating room, of course, and contact with an object like an instrument or a gloved hand. A basin has a large surface area, and that is a nice big area where airborne particles can settle. That makes good logical sense. And of course, the placement of the basin at the far end of the instrument table increases the risk of contamination from non-sterile, unscrubbed staff who could accidentally brush up against it. Again, logical conclusion. How do we prevent that contamination? Don't think that's too hard. It's important, though, to understand what we use the solution for because that influences what we do with it. Are you using it for washing? Are you using it for soaking? Are you using it for cooling instruments or drills that we've now just rushed out the autoclave because we didn't have a low temperature sterilizer? Is it saline or is it a solution we're using for wound irrigation? Is it something we're using for the vascular system? What are we using the solutions for? There are, of course, some guidelines that recommend we don't use bowls and basins of solutions. And in fact, when I worked in the UK for a couple of months, we were not allowed bowls or basins of water. We had a formalized irrigation system that we used. It was all orthopedic surgery that was hooked up to an IV solution. No pour water bottles, no bottles like that at all. So it was a different world. But having said that, comes the quandary that many guidelines recommend keeping instruments clean during the procedure, and the way to do that is using a wet sponge and normally with sterile water. So then, how do we try and eliminate these issues? And can we eliminate using water or using solutions on the instrument table? It doesn't really seem likely, and maybe it is possible, but if we are doing it, what are the strategies that we can use to prevent contamination of the fluids? So they divided the solutions or the solutions to the problem up into 3 things: during setup, during the procedure itself, and after the procedure. How do we manage this? During instrument table setup, they suggest that firstly you open a container of sterile water to use for cleaning. So that's a small container that you have on your tray that contains a lid preferably. This was interesting because I've never seen a container like that before in use. Then separately to that, they suggest opening a large basin with sterile water for soaking instruments in that have bioburden on them that are no longer in use. That's an important point. No longer in use, and that basin is kept on a ring stand separate from the instrument table. So that is something we currently all do. Open the sterile water for the container and for the basin as close as possible to the time of use. That's logical. The next thing that they suggest is that during the actual procedure itself, you should label the container and the basin after the sterile water is added. I'm truly not sure how to do that. I'm assuming that they have some form of sticker system or something fancy that you could purchase with which you would label these items. When possible, keep the small container of sterile water covered, except, of course, while you're using it to clean an instrument. Point number 3 is keep the instruments free from soil and debris using the sterile water from the small container and a radiopaque sponge during the procedure, as we know. Point 4, only soak the instruments in the large basin when they are no longer in use. Cannot be wiped or still have bioburden in them after wiping or rinsing. Place the wastewater. So I guess if you're rinsing a lumen instrument, you would want to hold it over the basin, the big basin, and not the small bowl, so that you don't contaminate the small bowl. And then lastly, they said if you need an instrument that's in the basin already, it's better to open a new sterile instrument rather than taking the one out of the big water basin. So that's very different in terms of how it is we work currently, because the majority of people use their large water basin to rinse and clean the instruments with throughout the case, and they go from the sterile field into the bowl, back onto the sterile field, and so forth. So that's a very interesting process and something we need to perhaps take into consideration. Then after the procedure, they state in the guideline that you should discard or contain the solutions that you used to soak the contaminated instruments. So that's a big volume of water normally. There is the opportunity, or I suppose the possibility, you could suck it up into the suction system, but of course that'll fill up your bags very quickly. You'll use a lot of bags and that'll increase your costs from a waste perspective incredibly. So we can't do that. So how do we contain the solutions? Remember how the answer is contain, not flush it down the basin, the scrub basin. Because of course that'll contaminate the scrub room. We've now just understood how many potential microorganisms there are in that fluid. So that fluid is something we need to concern ourselves with. So we need to find a way to contain it, to prevent leaking before transporting it to the decontamination area. And that is, I think, quite a thing. We often have big basins of water slushing down the corridors. So looking at ways to contain that, I think, makes good logical sense. Right, what else have I learned in the last little while? I spoke about the Key Surgical website where you can go to create an account for yourself and watch the on-demand webinars. This was one I did early this year. This was the AORN Guideline Updates, Electrosurgery and You. They began by discussing how the AORN do their guideline updates and what they do in terms of evidence rating. So they will review periodically, I think it's every 5 years. They don't necessarily do every standard. They specify which standards they want to focus on. And they start by looking at evidence that is non-research based and evidence that is research based. And then all of the evidence is given some form of rating at the end of the day. And then out of that, they then determine what they'll include in their guidelines and what won't be included in the guidelines. Very logical, very structured process that the AORN uses before just putting out a guideline. The guidelines that were reviewed apparently are these, according to this website and the e-learning that I attended: instrument cleaning, pneumatic tourniquet, specimen management, electrosurgical safety, laser safety, and safety around guidelines regarding local anesthesia. In this particular webinar, they really only covered electrosurgical safety. Of course, they defined electrosurgery as the use of radio frequency alternating current electricity to create heat in cells to cut or coagulate tissue, a concept we're all very familiar with. Then they spoke about ESCAR, that charred tissue residue and the importance around it. We all know that it's really difficult to remove. They spoke a lot about the fact that because it is so difficult to remove, and because of what's on the diathermy pencil or forceps, it does make it longer. Surgery takes longer, and that improves risk or increases risk and potential potential costs. It mentions that the eschar in the charred tissue is an insulator and that it's flammable. So if you look at the little image that I've just put up now, you can see how nicely a clean blade will cut. That's the first incision, one with a little bit more charring and one with even more charring. So the more charring that's sitting on the forceps itself, the less effective the device is, the more the potential for it to be flaming. I think the more smoke it creates, which of course, as we know, is harmful. We've gone through all of the risks associated with smoke already. So as a result, what the AORN are now recommending is that an anti-stick phospholipid solution may be used to decrease eschar buildup. And that high quality evidence supports the use of an anti-stick phosphate solution to reduce surgical time. So at the end of the day, it reduces time and it reduces risk. To the best of my knowledge, I stand to be corrected, but I believe there are certain disposable forceps and blades that can be bought that already contain these phospholipid solutions, and of course you can separately buy the phospholipid solutions to treat your devices with during the procedure. Very interesting approach and some new guidelines. Another additional update, now this is to AMI ST79, so this is the American guidelines around steam sterilization and sterility in healthcare facilities. And they haven't released a whole new document, so there's not a new document one can buy. They've just made a few amendments. So here's an extract out of one of those amendments. It talks also to diathermy. And it says over here, of course, as we know, damage to insulated instruments, including cords, can occur during normal use, processing with contact from sharp instruments, and the use of high voltage currents. Instruments should be organized and protected from damage. Repeated use and reprocessing of these devices and cords can cause damage to the insulation. Therefore, one of the steps, this is just the first step they mentioned, and I pointed to this one because this is something really new for us, is that instrumentation intended for use with electrical current should be tested for integrity each time. Not just inspected, not just identified, not just taken out of course, tested, specifically tested in a process in accordance with the instrument manufacturer's instructions for use. So there's an image on the right over here again from one of the other webinars that we attended, where they talk about these particular devices and the importance of having one of these in your CCT to properly test your instrument. So those are the new guidelines that have come out. Sadly, we don't have any specific guidelines around this in South Africa. And maybe it's something we need to look towards, how we can manage electrosurgical equipment in our operating rooms. Right, moving to the AORN guidelines in the era of COVID-19. So what they did in this special report, also published early this year, is that they looked at the already existing AOR guidelines and then interviewed the experts who actually wrote those particular guidelines, and then asked how those guidelines are applicable within COVID-19 constraints and circumstances, specifically focusing on surgical attire, environmental cleaning, design and maintenance of the surgical suite, and transmission-based precautions. So I'm going to go through all of those now. I took out the parts that I think were the most pertinent. There was a lot more information in the document, but these were the things that stood out for me the most. Scrubs worn under PPE during surgery on a patient with COVID-19 should be treated as contaminated. They should be removed immediately or as soon as possible. I hope not in the operating room. I assume somewhere in the change room. Do not launder these scrubs at home, an important point, because I know lots of people take their scrubs home to launder these days. We need dedicated shoes. We know we need dedicated shoes anyway, but we really do need dedicated shoes. And those shoes should not be worn into the house or into the community. And another important point, do not store your shoes in your personal locker, because shoes can appear to be visibly clean, but in fact may not be. So a very important point to note. When it came to environmental cleaning, the points they raised was firstly, of course, that the environment is the patient themselves, the area around the patient, and the equipment used on the patient. Always use validated products so that you're using proper documented products, no handy Andy or things of the like. Always clean before disinfecting surfaces. So the IPCs will teach us that anyway. At one point in the old days, we used to just use a disinfectant and wipe everything. But in fact, we need to make sure we clean before we disinfect surfaces. And importantly, allow enough time between cases for enough air exchanges to remove 99% of all airborne particles. They, of course, didn't define the timing because that depends on your HVAC system in your operating room. So allowing some time between cases, between the COVID cases, to allow for the removal of airborne particles. Design and maintenance of the surgical suite. Here, the focus was on HVAC, so air conditioning, and it got a little bit confusing, this discussion, because I have seen conflicting guidelines around this. The Americans and the Europeans seem to differ slightly in how they manage this. Of course, we have positive pressure in our operating rooms. We can hear that on the door. We keep it purposefully like that to push all microorganisms out of the operating theatre, to keep the surface or the sterile field as sterile as possible. That's the whole objective. But in doing so, what we might be doing is spreading COVID out to the corridors. It's a valid point. So there has been some talk about turning off the HVAC while you're doing a COVID-19 case. Others say no. It is a debate around that. They discussed the anesthetic induction room, which is more of a common scenario in Europe, where you put the patient to sleep in the induction room, which of course, while you're putting the patient to sleep and intubating the patient, that is quite a high risk time for potential for spread of COVID. And that to talk about that may be a nice solution, but not many of us have induction rooms in the South African setting. And they do acknowledge that there is a big knowledge gap in this area. So a point to bear in mind, we don't know all of the answers yet. What about transmission-based precautions? I think we know these all already, and I think we are pretty well putting all of these aspects into place. If you're operating on a COVID-19 patient, of course you are wearing the correct PPE. More importantly, you're wearing an N95 mask that fits correctly, not just slapping on any old thing, that you've got good fit. In there, they discussed the importance of donning and doffing of PPE, and I think we've learned a lot about that recently, and we're a lot more aware of the importance of donning and doffing our PPE correctly. Of course, this will also apply to us in the CSSD when we contaminate or decontaminating, cleaning the devices that are potentially contaminated from a patient who's a known COVID-19 patient. There is, of course, always the possibility of aerolization during different types of surgery, especially if you're doing anything down the throat. It increases the risk. There is a debate as to whether or not you're aerolizing COVID if there's blood splatter. Wearing N95 masks, and they suggest the use of a smoke evacuator, which of course you'd be using for diathermy anyway, or potentially could be using. Not seen that often in our country, but I'm hoping we move towards that. But there aren't concrete studies around that. So that's taking a look at the basic current existing AORN guidelines and trying to incorporate the concepts of COVID-19 and managing that. Thank you, Sharon Preddy, for sharing this and reminding me about the Australian College of Perioperative Nurses Journal. It's called the Journal of Perioperative Nursing. It's a free access journal, so feel free to Google it, and then you can go in there and access a couple of the interesting papers. This was quite a nice one, so we've got 2 papers from this journal to go through. This was about determining the attitude of the operating room nurses to radiation exposure. It was a descriptive study. We've covered radiation exposure quite recently, of course, in our 2021 Insight series, but this was quite nice because this was really about the attitude of the nurses. Very interesting paper. They begin, of course, by reminding us that radiation can have serious health adverse effects, and that includes effects on the immune system, the endocrine system, the nervous system, the digestive system, and the respiratory system. The research was conducted in 2 university hospitals in Istanbul, Turkey. I must say there's really nice work out of Turkey on occupational health related matters in the operating room. I'm quite impressed with the work that we see around that. In this research, 70 nurses were asked to complete an 18-question questionnaire. And the things they looked at, of course, is what the individual's role is. Are they a scrub person, a circulating nurse, or do they do both tasks? And what the experience was, the professional level of experience. I thought it was quite interesting that there were 33 of the 70 people had only had 1 to 5 years experience. I wondered if we did that in South Africa, what we would find, because our theatre staff, I think, tend to be a little bit more older or more experienced. Would be interesting to see those statistics. What they go on to talk about is that 74% of the staff, of the 70 people who had to fill in the questionnaire, had been exposed to radiation in the last year. That only 35 of them, so half of them had received radiation exposure training, and that's the thing that I spoke about last time as well. I don't know that we do that well. We do it in our initial training when we do our theatre course 20 years ago, and then no other updated training around that, and that does worry me quite a lot. What were the types of PPE they wore? Protective eyewear and gloves. 20 of them did. Thyroid shield, 44 of them. Lead apron, more people tend to use by the looks of it. Was a dosimeter used? Those results were quite surprising. Only 25 of the 70 people interviewed used a dosimeter. I thought that was a bit sad. It's my impression, and it may be right, it may be wrong, that we tend to use dosimeters well, and perhaps that's only the private practice. I'm not sure what happens in provincial practice, but those of us that are exposed to radiation should really be wearing dosimeters. 81% of the people said they did use protective equipment, but obviously the type of protective equipment seemed to range, and certainly those who underwent training seemed to be to take the necessary care when needed. If you look at the table on the left over there, it goes to look at the relationship between receiving training and the actual protection used. And thankfully, it does seem that the more people had been, the people who had been trained were more likely to use proper protection. They discussed the fact that more than 7 million healthcare workers worldwide are exposed to occupational radiation, and that the majority of nurses know the harmful effects, but sadly do not pay attention to the protection measures. That is very sad. The next paper I read from the ACORN this year, and here goes a very difficult term, ergo-ophthalmological risks, hopefully I got that right, associated with dry eye in the operating room. Interesting concept. So the prevalence of dry eye disease varies in normal adults between 5 to 50% and between 5 to 75% in postmenopausal women. However, the risk of dry eye is much higher in the operating staff. It's like 56% higher. And of course, the potential harmful factors include surgical laser, electrosurgical equipment and instruments, chemical antiseptic, surgical smoke, the use of HVAC and anesthetic gases. Sadly, in this article, they don't have any solutions because I don't think there are any solutions really. We're in an environment where we're exposed to a number of things that potentially will cause dry eye and make that risk a hell of a lot higher. So those of you who have a dry eye issue, now you know why. And then moving on to our last topic for today's webinar is about waste management in the operating theatres. And waste management is a very difficult area and is a topical area because waste can be expensive to manage. And of course, we've got the issue of it being potentially biohazardous material. This is a study, an observational study that was undertook at one Italian hospital. So just interesting to see the statistics and the amount of stuff out of this. Of course, the background is that each day the operating theatres produce a huge amount of waste. The aim of the study was to understand how waste was segregated and how it was disposed of in this one particular Italian hospital. I would really love somebody to take this and do it as research in the South African setting. Needless to say, if infectious waste gets mixed with non-infectious waste, it can be potentially dangerous. It exposes healthcare workers to biochemical risks, and it potentially increases the disposal costs. Previous research had stated that 70% of hospital waste can actually be recycled, reused, or segregated correctly, which could save a lot of money. Hazardous waste, of course, costs 10 times more to dispose of, and it is significantly worse for the environment because we burn a lot of that hazardous materials. So using a structured observation tool, they witnessed 88 surgical procedures and observed 21,000 throwing away of goods, and the findings were as follows. The preoperative phase, which they defined as before the surgical incision, was actually the biggest issue. That's where the highest percentage of incorrect waste was. If you have a look at the table over here, the incorrect disposal happened there, and that was the highest time where waste was actually produced. So that was really the opening of the packs, opening of the sets, opening of all the disposable items that were required. Intraoperatively, I think we open probably a few less things. It's only if you need stuff extra or additional, or perhaps it's the anaesthetist who's opening one or two things. And postoperatively, those weren't the biggest area of concern. The types of waste that they looked at includes hazardous or sharps, recyclable materials, plastic stuff, undifferentiated municipal waste, cardboard, and glass, of course. 30% of the waste produced was indeed hazardous and sharps materials, and that's what really needs to go into the hazardous material bins. 57% of the waste was disposed of incorrectly. I think a lot of us err on the side of caution, or sometimes on the side of laziness because it was the closest bin. I'm not 100% sure why, but it is something I do believe we can improve on. If you put the waste in the right receptacle and you have the right receptacles available, perhaps we can better manage this. Yes, there's a risk involved from an infection prevention point of view. Of course there is, but if we do this cautiously, I'm sure that we can find ways of managing waste better. In their particular research, they found that between 57 to 71% of that waste could have been actually recycled. That's quite a high percentage. So although I'm saying be cautious and go out there and recycle your waste, you really need to be very careful about how you do it. Thank you very much for joining me for today's now short, sweet, and compact session. We spoke about contamination of sterile solutions on the sterile field. We discussed the latest AORN updates and around the importance of managing that charred tissue on our devices, on our electrosurgical devices. We looked at what the AORN has to say about managing COVID in the operating room. We covered two very interesting topics from the Australian Nurses Association. And lastly, we touched on waste management in the operating room. Thank you kindly for joining us today.